And now I'm happy to introduce Dr. Louise Restrick. She'll tell us about how you can improve healthcare interventions for patients with COPD. Restrick works in London as an integrated consultant. She shares leadership of a multidisciplinary respiratory team at Whittington Health. I've been practicing that all weekend, but it didn't help. Restrick is a respiratory physician, and she has also contributed to the London Senate program named Helping Smokers Quit. So, Louise, we are glad to have you, and you're free to start when you're ready.
Tack, good morning. And now I can speak English. Thank you very much for inviting me to be part of a whole day on value-based healthcare, which is very exciting, and to share the start of our learning of applying value-based respiratory care in London, because this is very much a journey. I think I do need to say that I have no conflicts of interest except that I'm a convert to value-based healthcare. And I think it would probably help to start with a little bit of context. So I'm a clinician, and this is why I come to work. How many clinicians are there in the room? So I suspect what I'm describing is why you also come to work. So I want to deliver the best possible outcomes for my patients. And by my patients, I don't mean the patient in front of me. I mean those people in the population we're responsible for who are living with respiratory disease. I actually want to improve those outcomes because your outcomes may be better than ours, but they're pretty dreadful in London for respiratory patients. One of the lovely things about being a clinician is working with patients, and we have to be honest that affirmation from patients and families, which our back office staff don't get, is very rewarding. And actually, we also want to be respected by our peers. Again, I don't know what it's like for you, but respiratory in London is very busy at the moment, and the days can be hard. And actually, what our days feel like, and for our trainees and how we instill morale in them, and that we have a workforce who's well, both mentally and physically, matter, and it matters to me personally. I've been a respiratory consultant for 20 years, and actually what keeps the day job interesting is learning new skills and that things don't just stay the same. And one of the things that's come out of using a value framework is the skills that I particularly value being able to use are treating tobacco dependence, and thinking about how we have conversations in an evidence-based way, in the same way anything else we do would be evidence-based. So I wouldn't put a drain into someone's chest unless I'd been trained how to do it. But we don't apply the same rigor to conversations. And I think probably that's all summed up, that actually we like autonomy, we like a purpose, and we like to be in control of what we do. So who are the patients that we admit to hospital in London? Oh, I've gone backwards, sorry. You can see here the range of complexity. I can't remember the last time I looked after someone who had a single long-term condition. I can't remember the last time I saw someone who was only on one medication. And because I'm a respiratory physician, it's not just tablets, but it's a very wide range of inhalers. Although I care about respiratory disease, I look after patients as people, and I can't remember the last time I saw someone who only had a respiratory illness. And the people we look after have dementia that may or may not have been diagnosed. They have drug and alcohol dependence, and we have an increasing burden from morbid obesity. Many of the patients we look after have difficult life situations, and you can see the range of communication issues. All of this means that there's a high risk of premature mortality. And that although we like to talk about self-management, to do that, you have to have a certain amount of health literacy, and you have to be able to have mastery. And so this is not a surprise that we have this and we have this, because COPD, which I'm going to talk a bit about now, is really a disease of inequalities. So that's my perspective of patients. But actually, we know that when we start to talk about patient agendas and clinician agendas, they're not quite the same. So what is it that actually respiratory patients tell us about their needs? And we first started asking them back in 2002 when we set up our community respiratory team. And what we heard were 4 themes. And it would be nice to say in 2018, we've cracked some of these, but the themes are absolutely still the same. First of all, patients say, I don't want to die. Secondly, they tell us that breathlessness is disabling, but more important than that, it can be very frightening for them and for their relatives. We don't talk to each other enough. Hands up, who is a GP or community clinician? Oh, so I'm mainly talking to hospital-based clinicians. We need to widen the conversation. Same issue happens for us. And most important of all, the patients are saying to us they want better conversations with us. So, how are we going to delay death? Improve the experience of living with breathlessness, have conversations that work better for patients, and make care feel more joined up to those experiencing it. So this is complex and it might feel overwhelming. And I suppose the things we need to do is, first of all, identify what are the right things to do. We then need to be redesigning our pathways with patients and families so that they're shared agendas from the start. And because it's complex, we probably need systems so that we do all of those right things. And the terms that are bandied around a lot of integrated care may be one way of doing this. I actually think it's also helpful to think about collective clinical leadership. Back in 2010, the NHS in England also was starting to prioritise clinical leadership. And I was involved with a group, multidisciplinary group of clinicians, starting to think about what would we want to do differently within respiratory care in London. And at about the same time, this has already been referenced, this fantastic paper came out in the New England Journal of Medicine by Michael Porter and Tom Lee. And then Michael Porter came to London to talk to clinical leads, as you are, about value-based healthcare. And this is our London respiratory interpretation of what value means. And I was interested in the hands up, I had to have it translated, of who understood what value-based healthcare meant. So this is our simplified version. And the reason we really like it is it works for clinicians talking to commissioners. Because I've already said this is what we care about, health outcomes, but they have to be defined by patients. So that means I don't want to die and I want to live better. But we also have responsibility for stewardship of the resources, because there are a limited amount of resources, and therefore as a clinician, a relatively well-paid clinician, it's really important that what I do with my time is of best value, not low-value interventions. So why might this be useful in COPD? Well, the first thing is I don't want to die. This is where we were, and this was enough for our government to start us thinking about COPD a bit more, because we have 30,000 deaths of COPD in the UK each year. But these are the other reasons why we might want to use value. It's a common condition. Not only do patients die from it, but we've talked about the inequalities. Patients die from it young. It has high costs, and while as health professionals we might be interested in our costs, the cost and the burden to patients and families are massive, and that's because of the disabling breathlessness. It also causes respiratory failure, which is why people need to be in hospital, because they die from it. And surprise, surprise, there is enormous variation in the treatment offered, and therefore there is enormous variation in outcomes. So we went back, clinicians like the evidence, we practiced evidence-based healthcare, so it's no good coming up with a list and thinking this would be high value. We have to go back to the evidence. So if you go to a talk, how many respiratory clinicians are there here? If you go to a talk on COPD as a general physician updating yourself, I would guess that most of the talk might be about inhalers. So we went back and looked at What is the economic evidence? Where are the quality-adjusted life years in COPD? And this is what we found. The evidence was there, it just hadn't been put together like this before. So this is the COPD value pyramid. We were delighted to see it on the front page of one of our best respiratory journals, and it rather turns on its head what are the interventions we should be doing in COPD. And it gave us a framework to think about how we might want to do things. Because this is what it looks like currently. And this is the data set from Wales. So the whole population of Wales using the GP database, does it look like a pyramid? And that's because everybody's been to the talks and heard that we should be using inhalers in COPD. One of the reasons they don't add value, because value is outcomes divided by costs, is that first of all, 90% of patients don't know how to use an inhaler. Secondly, 90% of health professionals don't know how to teach an inhaler. And thirdly, cost. So this is a bag that we put together from a couple of patients back when we were first showing this slide. So this is, as in 2011, the cost of that bag. Not value, cost. Anybody want to guess? You have to convert it into pounds for me because I'm not very good in krona yet. £800. So there's quite a bit of smoking, cessation and flu vaccination that you could get for £800. So we can then think about relative value, because if we've got limited time, we want to spend more time on the higher value interventions and less time on the lower value interventions. If I've got 15 minutes in clinic, I can either spend that 15 minutes talking through the 100 inhalers on the market with a patient, or I could spend some time doing these bottom three things. So, flu vaccination. Hands up, who's had flu vaccination? That's probably similar to in England. Most of our patients, 80%, have had flu vaccination. However, that means that 1 in 5 haven't. And who in the 1 in 5 who haven't? Probably the most needy, the housebound, those who are at highest risk. So we've changed what we do about flu vaccination. We now always ask about it. We talk about it and recommend it. And if we see someone in clinic or on the ward who hasn't had flu vaccination, they have flu vaccination. And if this is going to be a partnership, what we'd like is our patients, when they're seen by a clinician who are unwell with respiratory disease and might get unwell with flu, our wards are full of patients who are really sick with flu currently, they might say to us, have you had flu vaccination? So this is, if you don't have mandatory flu vaccination, and very few places do, look what's happening within health professionals. So we may think our beliefs and behaviours are evidence-based, and we may challenge our patients that they're not being evidence-based, but look at this. So the blue line is nursing vaccination. I'm guessing most of the clinicians in this room are doctors. The red line, we're not the top line, is doctors who have flu vaccination. So there's something about beliefs and behaviours here, and there must be something about leadership, because look at how it varies between trusts. So we were really interested in this as the London Respiratory Network, and we therefore thought with that amount of variation, we might see a difference in staff sickness. And so we did. We found that for every 10% increase in your staff flu vaccination rate in your acute trust, you will have a 10% lower sickness rate. At the moment, where we have terrible trouble recruiting nurses and we have massive staff shortages, this seems like a really important thing. So you won't be surprised to see that at the Whittington, where I work, we have for more than 10 years had a philosophy that you don't work on our respiratory ward if you haven't had flu vaccination. And this is a patient saying to me, have I had my flu vaccination? Because that's where we should be getting to. So the next thing that I want to spend a little bit of time talking about is smoking. Because what does smoking have to do with hospital admission? And I suspect your data may be similar to this. So on a respiratory ward, at least 20% of patients in hospital will be current smokers. On a mental health ward, it will be 50%. In COPD, the smoking rate in patients admitted to hospital was 40% in 2008. In 2018, it's still 40%. That says something about we're not treating this. The shocking thing is this data, the smoking status, didn't come from hospital records because hospital records don't know whether their patients smoke. It came from GP records, and we only knew in 3/4 of patients. And yet it's responsible for 500,000 adult admissions, more than 1 million smokers admitted to hospital, and 2.6 million episodes of care. And I bring you back to what the patient said matter, dying. So this is a map of London. Here's the Thames. This is where I work in inner London. This purple area, all of these purple boroughs, 1 in 5 people will die as a result of tobacco smoking. So it was 10 years of being a respiratory consultant before I'd ever done any smoking cessation training. So hands up who's done smoking cessation training here. Hands up who sees smokers. And I think that's partly an organisational issue, because for years and years we've been told that smoking is a lifestyle choice, it's public health's responsibility, it's not my problem. But actually there's a different way of thinking about this, because smoking is actually nicotine dependence, it's tobacco dependence, and it's a relapsing, remitting, long-term condition that starts in childhood. And as a clinician, my job is to treat diseases. I treat alcohol dependence, I treat drug dependence. Why wouldn't I treat smoking dependence, smoking as tobacco dependence? And if you decide to do that, that then gives you a different paradigm to use. Because look at how it is currently. This is COPD data nationally. Currently, 1 in 4 smokers admitted to hospital with COPD, so they're admitted with a disease caused by smoking, are offered nicotine replacement therapy. So none of this happens quickly, and we've been really lucky at the Whittington to have had fantastic leadership from one of my colleagues, Myra Stern. So back in 2004, we started on a journey, a team journey, which was consultant-led, where we got smoking cessation specialists embedded in our teams. And we like that because not only does the smoking cessation specialist see the patient, but we get to, by osmosis, pick up what they're doing and start to do it ourselves. So they have multiple interventions on the ward from the clinicians and the specialist. They have behaviour change support. They have a range of medication, and we've made it part of what we do. Do I like doing this? Yes, I do. I would now describe myself, rather than a respiratory physician, I would say I am a clinician of tobacco dependence, breathlessness, and respiratory failure. And the reason I like it is because it works. It makes a really obvious difference to patient outcomes, and it's very rewarding. But you want to see the data rather than my anecdote that it works. So we incentivize smoking cessation with a commissioning tool, because sometimes it's good to have a push and as well as a pull, and you can see how things started to change. So smokers were given advice. This is our national data on smoking cessation treatment for people with COPD, not perfect, but well above the baseline, and referrals to the smoking cessation service. We also measured our own outcomes, because you have to be responsible for what you do. And we get a 50%, not a 4-week quit rate, which is what smoking cessation services measure, but a 6-month quit rate of 50%, which really is very meaningful from patient care and actually benchmarks us very well against a standard smoking cessation service. What we didn't do, and I would urge you to think big in the work you're doing. We didn't for a minute think that we would have bigger impact, so we measured processes. I just want to share some work with you from Canada. Some of you may have seen this fantastic work from Ontario. So they did a 2-group study looking at 8 hospitals, where they did really what I've described to you. System-wide big approach. And this is what they found. We're talking 1 year here, brief smoking advice, follow-up, prescriptions, they halved mortality from 11% to 5%. And because you've got commissioners wanting to reduce admissions, they halved, these aren't tiny changes, they halved readmission rates. And so I regret that we didn't do those kind of measurements when we stepped out in this work. Okay, in the last few minutes, I want to come back to some of the harder stuff, which is perhaps even the more important stuff. So, unlike diabetes, we don't have an easy measure of how things are for our patients because their issue is breathlessness. And as I've said before, conversations. So how are we going to think about that? The first thing is that we need to split up breathlessness, which is a symptom, which we find about by asking and listening to the experience, from respiratory failure, and I found this in my bag because I carry it everywhere, which we measure using an oximeter. And that matters because if you have respiratory failure with your breathlessness, you need to be in hospital because we can save your life, or not, but there is evidence-based treatment. Whereas if you're breathless with a normal oxygen level, it's okay for you to be at home. But you can only be at home if you're not so frightened that you can't manage your breathlessness. And so there is an obvious value thing that's missing here. And I was interested, lots of your pictures, I couldn't understand a lot of the speaking, but I saw stethoscopes. Everybody gets given a stethoscope. It costs £180, a good one. An oximeter costs £30. Why haven't we caught up with technology? Because any clinician assessing a breathless patient, wherever they are, should have and use an oximeter. So we provide all of our teams with one. It just feels like one of those massive blind spots. I think with breathlessness, we really need to pool our resources with our patients and start thinking about this differently, because where we are at the moment is, I think all we can say is that we need better ways to assess it, better ways to diagnose it, and better ways to treat it, because it's pretty appalling at the moment. What we do know, and this is where I'm very jealous of you in Denmark, is that one of the interventions that makes a difference is pulmonary rehabilitation. And I wished our inner city pulmonary rehabilitation looked like this, because it looks a very therapeutic way to do it. I talked at the beginning, and a theme that's been coming through is conversations and how you have conversations with patients. And there is an evidence base for this. And we've used the work of an organisation called the Health Foundation quite a lot, because they've reviewed what is the evidence for how you have conversations that might enable behaviour change. And the answer is motivational interviewing. So the first question is, as clinicians, do we think we need these skills? And I have to say, the first time I was offered this course, my response was, I don't need to do this. I'm a patient-centred clinician. I know how to have these conversations. But actually, having been on the course, I realised that there was a lot I could do to use my time better to achieve what I wanted to achieve. A course is a start. Actually, that isn't the best way of embedding these skills. What we've found is that we have psychologists in our team who, in the same way as smoking cessation specialists, we can work from and learn from and can see our patients. The evidence base for this is still soft, but it's one of those things that I think if you talk to teams who have psychologists in them, will say it works. And these are this is a paper from the London Respiratory Network where we reviewed what the evidence was and what clinicians' experience were, and you can also read about our Whittington experience. I hope it seems fairly obvious. If you come back to the COPD value pyramid, there's going to be a role for psychologists and motivational interviewing at every level. We've seen the beliefs and behaviours in flu vaccination. Smoking cessation, one of the key arms of treatment, is behaviour change. And pulmonary rehab, while it's fantastic, there is a very low conversion rate from referral through to completion, and you only benefit if you complete. There are a couple of other enablers just to mention, and these are only examples, and I'm sure other people have similar things. The first is that we've got a number of interventions we want to make in COPD. So one of the things we can do is bundle them together. And this is the COPD bundle that was developed in Northwest London, and you can see the content is very similar to the value pyramid. And what the team putting this forward found was that before the bundle, we're not very good at doing the interventions we should be doing. Pulmonary rehab referral for 14% of patients, smoking cessation for 18%. With the bundle, you can increase some of these things, the self-management and the inhalers, nicely. What's still difficult is pulmonary rehab. And look at this. The follow-up, the coordination was unchanged, which is probably a nice step to lead on to thinking about how we think about that coordination. Again, because we'd seen this, we wanted to try it out in London. So working with our commissioners, there was some incentivization of COPD bundles. Does it work? Well, what we found was that hospitals who used the bundle, so really as a reminder, as a prompt to do the right things, had a change in the increase in admission rates compared to those who didn't use the bundle. So I talked about the lack of change of follow-up and how do we make things feel more joined up. I think the biggest thing is that we have to want to make them feel joined up. And there's a lot of banding around in England about the term integrated care. And so I think if you use the term integrated care, you should be willing to define it. And this is our definition. It's person-centered, evidence-based, high-value care that feels joined up to the person experiencing it. The thing about that is it has nothing to do with place. So what I do as an inpatient respiratory consultant looking after sick patients on the ward is integrated care. It isn't just what happens in the community. And we try and embed a system where it happens all the way across. And to do that, you need a whole group of leaders doing the same thing. You need buy-in from all your team members to want to do the same thing. And the more effective the communication and the easier it is to share information, the more joined up it will feel. What we've realized is the place where patients fall between the gaps is the transitions, that moment when you come into hospital, that moment when you go home, that moment when you go into the nursing home. So we've particularly focused on those. And the value of being able to have a system-wide approach, this is my last slide, is just to talk about one other enabler of higher value respiratory care, is that we've been able to replicate what we do in the hospital within the community by using something called a local enhanced service, where the GPs are incentivized to do those same interventions. And this is the GP's work. What they were able to achieve is a 25% increase in COPD diagnosis, massive increase in pulmonary rehab referrals, and again, using this same model, a reduction in COPD emergency admissions. I would just make the point, these aren't all the things that matter to patients, but whenever you're wanting to prove a new service can be continued, you have to focus on the reduction in emergency admissions. I hope that's given you a little bit of a flavour of how we've adapted a value-based framework. I would just like to end by really saying that what I'm presenting is the work of many colleagues who I've been privileged to share leadership with and work with, both in the London Respiratory Network, in the London Senate Helping Smokers Quit team, and perhaps most importantly, because it's my day job, with the local team I work with at the Whittington and in Islington CCG. Thank you for inviting me.
Thanks, Louise. That was really interesting. If there's any questions, feel free. I would like to start. About the economy, it's obvious that the patients got better treatment, but did you save money, or is it at the same cost, better treatment at the same cost, or did you actually save money or activity?
So I think that's very difficult to answer, because measuring that is extremely difficult, because patients present to different hospitals. We don't have costed bundles of care for individual patients. I think what I would be confident to say is that we have switched where we've spent the money. So that what we're looking to do is to reduce the spend on inhalers, and actually historically in our area we've been a lower spend on inhalers. I'd love to be able to say we were fully invested in treating tobacco dependence, but we're not. I think one of your questions earlier was about data and sharing data, that we need some really big population data sets to be able to show that we've truly saved money.
Yeah, this data sharing is a big issue in Denmark cross sectors. Is that a big problem issue in?
Yes.
So even you have a national.
Yes. So one anecdote: I showed you the inverted value pyramid for what's actually happening in COPD care, but did you notice where I showed you it from? Wales. I work in England. That's because the NHS England structure wouldn't allow the data sharing, but the Welsh government would. What I would say on data sharing is that, yes, of course we need it. We need it on an individual patient level, and we need it to understand outcomes and processes. And after 20 years of being a consultant, this year I've been able to access GP data for the first time for patients, which is fantastic. But all that means is it's easier for me to do it. I used to do it before, but it took longer. So 5 years ago, if I was seeing someone in clinic with difficult asthma, I would email the GP and ask for a copy of the number of inhaler prescriptions. Now I can just go into their system, but it's about deciding how important it is to have that data, and I think the data sharing just makes it easier.
Okay. What is your one or two best advices for people who's going to implement this in a Danish clinic, a Danish everyday?
So I think that's presumptive for me to advise that. I think it's really about I would hope there maybe connect with some of the things that we've talked about. Personally, you will see, I think the big mileage is a change in thinking about smoking as not a lifestyle choice, but this is tobacco dependence. But it's got to be something that works in your system. There isn't a one-fit-all solution, and it has to belong and be owned by the clinicians who are putting it forward. I suppose my second reflection rather than advice, which I suspect will also resonate, is this will only work if you have, and you saw the picture I had at the beginning, which is called Boyding, of the birds in flight. If you have a number of leaders where we're each given our own space to lead, but everybody knows roughly the same direction they're going. So you haven't got one person prescribing Seretide and another person prescribing Foster and another person prescribing tiotropium. These are all inhalers, but we're all going forward in the same direction, because that's the only way to achieve difficult change, and this is difficult change.
Okay. Yeah, there's a question there.
Thank you very much. Could you tell us how you manage the integrated care in your network in the day-to-day basis? Is it by telephone or email, or how do you integrate the patient in your integrated network?
So and I'm now just talking about the Whittington Hospital, which is where I work, is an acute trust for a population of 400,000 people. There are 2 CCGs, so groupings of GPs, different boroughs with different systems, one called Islington and one called Haringey. We have 400 inpatient beds, about 100 of them are medical beds. The way we do it practically is that we have a community respiratory team who work out of 3 localities. One, the hospital, only because it's nicely located for the north part of the area, one in the east and one in the south. And those are respiratory specialists, physiotherapists and nurse specialists who will support patients at home. And the way that they do it is by a mixture of telephone, the patient rings up, going to patients' homes, and I think one of the best definitions of integrated care is a mobile phone and somebody having your number. So, hello, my name is, this is my number. And you make it easy for people to ring you. Nobody misuses it. So if the nurse, specialist or physiotherapist aren't sure what's going on, they will ring one of the consultants. If they're admitting in a patient, we will let A&E know they're coming. We will have made a plan for making sure they aren't given too much oxygen. And then it will be, if they're not admitted, it will be working out with the patient and the GP whether they need antibiotics and steroids, how soon they need to be reviewed. So it's very much individualized, but that's the home support part of it. That same team are the team who deliver pulmonary rehabilitation, and we obviously put a lot of emphasis on that because that's one of the main treatments that supports. Does that answer your question?
Now you have been speaking about COPD patients. What about value-based healthcare for other patients? How is the situation in Great Britain? Is it a big thing, this value-based healthcare, or are you one of the few?
So I will turn it round and say that was interesting seeing your case studies you're doing, and I was disappointed that respiratory wasn't in there. I think it's quite brave what we've done in respiratory because we've gone for value-based healthcare, even though there aren't easy measures. There isn't an HbA1c to measure. But I think there's a lot of yield. I actually think tobacco dependence would be a very good model to have a go at in a region, but do measure mortality straight away and readmissions. The other areas that have really led on this in the UK, and I think there are some diabetes clinicians here at diabetes, this makes complete sense in the diabetes model, the Desmond, the Daphne, the supporting, and the Health Foundation, who I talked about, were very much at the forefront of setting this up with a program called Co-Creating Health, which had 3 arms to it. One was enabling clinicians, one was enabling patients, and the other was quality improvement. And the areas they did were diabetes, respiratory, and anxiety and depression.
Okay, thanks a lot. Should we give... oh, that's a question there.
Christian Plessen from region of southern Denmark. Thank you. Wonderful talk. So my question is, how are the conversations with your colleagues in your hospital or your trust going? Other specialties or?
Yes. So we have the Rogers curve. And probably the conversations with my colleagues are on the Rogers curve. You find your bedfellows and you move with them. So because we've had co-creating health in the hospital, there has been an opportunity for a lot of people to be trained in motivational interviewing. The people who get this are the long-term condition clinicians and to some extent mental health clinicians because, of course, they will have done quite a bit of this. I'm a bit surprised that it hasn't connected for care of older people. And I think I would say it's a work in progress, but feels completely obvious the space we should be going is into anaesthetics, pre-op and surgical clinics if you're going to do tobacco dependence. We are now helped by a chief executive who really believes in this. And I think there is so much you can do from the bottom up, and I would say a clinician leading a service is bottom up, but actually where it works best is when you have your board and your chief exec and a board level sponsor, and the two start to mesh like that. But I don't feel disheartened, I feel hopeful.
Yes. We have a question.
Is it working? Yes, now it's working. Birgitte Nybo, Bispebjerg Hospital. I'd like to ask you, these supportive teams out in the community, are they working 24/7 all days, or is it only in daytime?
Yes, so we're in the real world and we are also resource strapped. So our community team works 9 till 5, Monday to Friday. Actually, there was another service that did some modelling about how often it was useful to have somebody available in the night and at the weekend. And for the costs, we didn't think that it added value, although there is a massive push towards 7-day working. And that's to do with our focus would be on enabling patients to feel in control of their breathlessness and actually working with them so that they're less frightened, because it's the fear calls in the night that call the ambulance and the fear calls at the weekend. And what's interesting is that patients aren't stupid, and I still see clinicians who aren't wearing these, who are assessing breathless patients, which completely shocks me. And we come around and talk to a patient on the ward round and give them permission to talk about whether they have one of these and say, do you have an oximeter? And they say, yes, of course. They've been online, they've bought it within 24 hours. They're smarter than many of our junior clinicians who take several weeks to get around to getting hold of one. And that's because it enables them, because they also know that if their oxygen level has dropped to 70% and they're breathless, then it's right they call an ambulance. If their oxygen level is 94%, but they're breathless, then they know to use the breathless mastery techniques, to use the fan, to use the pursed lips breathing, to use the candle breaths, and to manage through it. So that's been our way of adapting, and I'm not sure that we would necessarily go to 24/7. Now I'm stuck.
Yeah. You'll have to stay here with me the rest of the day then. Any more questions? Yeah.
Helene Hvidmann, the head of the Danish Medical Association in the capital region. Thank you very much for a lovely talk. You talked about collective leadership, or the fact that and I just wanted you to give some thoughts on that, because one of the things that we're trying to implement here in Denmark is to have a treatment or a patient responsible doctor, really having one person to be sort of one-to-one, the one to take care of one patient. And one of the issues naturally is that many patients have multiple diseases and therefore have contact with multiple consultants. What are your thoughts about collective leadership in this respect?
Thank you. That's a really good question, and I actually took... Normally, thank you. I actually took the slide out about that because of time. I think there are two themes there. Which are about not only talking about values, but talking about values. And I think that first slide I showed about why I get up and come to work. So it's about appointing people to the team who share those values and actually overtly going back and talking about those values. I also took out a slide at the end about how much trainees like working like this. They feel ground down. They don't want to feel I'm seeing just another patient with COPD. So it's about putting the person back in the patient. And I think the other thing that in the collective leadership that I would say is about also talking about the how we work with patients. So we use an acronym CREDIT, which is spelt with a K rather than with a C. And reflect back, having heard the words from patients, to them what we're using. And it's written on a whiteboard in our office, where K is for kindness, R is for respect, E is for empathy, D is for dignity, I is for interest in a patient as a person, and T is for trust. And what's really nice about those 5 letters is the R and the T, the respect and trust, are what make teams work. And this is the nice thing about using value as well. If you then find, and you asked, how does it apply to things outside respiratory? You then find you're thinking about, well, is this a good use of my time? Am I using the kind of language that would work in the way that I would want it to? And the other thing about thinking about language, coming back to your question, is, of course, what we're talking about is influencing. influencing is behavior change. So actually having the motivational interviewing skills that one wants to use with patients, you find that without realizing it, you're slightly using it with colleagues. So you find out what their agenda is before you launch in with your agenda, and it actually works really well. Well, sometimes.
Yes. Should we give Louise a big hand?
Thank you.
And while Mr. Bean is quickly